Thanks, Varun. Thanks, Patrick, and thank you for having me, and thank you to everybody for coming to listen to my talk on this evening. I'm sure many of you are pretty tired from the day, so I'll try and keep it as concise as I can, and hopefully as interesting, as well as giving you enough science to think about as well around COVID. So I will now share my screen. Hopefully, I think it's this one. There we go. Excellent. So a bit of background about me. I qualified in 2001 from Edinburgh Medical School. So I've been a qualified doctor now for almost 2 decades. Overwhelming majority of that time has been working, in the NHS. And I initially trained in interventional cardiology and then shifted to prevention in the last few years. So we're going to talk about COVID-19 and lifestyle medicine and the immune system. Why is this not clicking along? Just bear with me, the slides are not going along as they should. Let me just try stop share and do it again. Apologies, try this. Okay, excellent. It's working. Great stuff. Right. Okay. So many of you are aware, it's been, I think, rammed down our throats, certainly for the last few months, that there's been a very strong link between obesity and poor outcomes from COVID-19. And the reason for that on a very basic level is excess body fat itself actually contributes to immune dysregulation. So in other words, if you've got excess body fat, I will explain that it's much beyond just obesity, then your immune system does not function properly, both in terms of its initial how it deals with the initial infection, but also in terms of the exaggerated response known as a cytokine storm that with COVID-19 causes the acute respiratory distress syndrome. And actually, for most of those people that sadly succumb from COVID-19, that's how they die. You're also probably aware that age is a big risk factor. In fact, age itself is the biggest risk factor for death from COVID-19. And if you look at the data, if you're over 60, then you're 23 times more likely to die from COVID than if you're under 60. And one of the reasons for that, or the main reason for that, is just part of the aging process is the immune system also loses its robustness. And this, we call this inflammaging, but it's not inevitable. It's something that clearly, if you've already got underlying conditions or chronic disease, then it's going to be, your immune system is going to be even more adversely affected. So I started looking at this data and started writing and advocating, trying to get the message out around lifestyle quite early on. So before even, we got into lockdown in the UK, there was data coming through from China that 60% of the people that died from COVID had high blood pressure or type 2 diabetes. Italy revealed that 99% of all the people that died had at least one underlying condition. The average age of death was 82, and most of those, the average number of conditions for the people that died was 2.7. Data from the United States, from New York, also as you can see there, the main conditions associated with hospitalization and death are high blood pressure, obesity, diabetes type 1 and type 2, and morbid obesity as well as heart disease. Similar pattern again from data collected in Louisiana, diabetes, obesity, chronic kidney disease, cardiac disease, underlying lung conditions, and people who are immunocompromised are also, up there. Now, this is a really important slide because it highlights quite a few different things. I think the first thing to mention is that people with type 2 diabetes who had poor glucose control and admission to hospital, this is data that was collected from China. Those patients who had poor glucose control in particular had a 10-fold increased risk of death compared to people who had better glucose control. And that's just in hospital admission. And the reason for that is that viruses and bacteria thrive off high blood glucose. We've known that for a long time, certainly in secondary care. Type 2 diabetics or type 1s with poor glucose control are much more vulnerable to complications from infection. Now, in primary care, what's interesting as well, and something that we kind of acknowledge but haven't really thought about carefully, is if you look at, pre-COVID, if you look at chest infections, you look at pneumonias, influenza, if you're a type 2 diabetic, and in particular your glucose control is poor, then you're 6 times more likely to visit the GP in that year with a chest infection, and also similar fold likely to be hospitalized with a pneumonia. So, it's something that's very well established in medical science. Poor, glucose, high glucose is not good when it comes to infection. So the data tells us, as we know, that obesity doubles the risk of death from COVID-19. But what's more important, and is actually the big issue once you take age out of the picture, is metabolic syndrome. And if you have metabolic syndrome, and I'm going to define that properly for you shortly, then your hospitalization rate with COVID is 5 times greater, and your risk of death is 3.5 times greater. So it's a much bigger problem than obesity. So how do we define metabolic syndrome? Well, first of all, optimal metabolic health is having absence of all those, or actually having all of those 5 factors you can see here in the box, the shaded box. They should all be within normal range. So you want your blood pressure to be less than 120/80. Above that, you have pre-hypertension initially, and then you have mildly raised blood pressure, 160/100, as many of you know. HbA1c, which is basically you don't want to be pre-diabetic or type 2. Waist circumference for Caucasians, males less than 102 centimeters and less than 88 for females, and for South Asians it's less. And the reason it's less for South Asians is multifactorial, but one of the reasons is that it appears that people from South Asian backgrounds develop the sort of conditions associated with metabolic syndrome, the risk factors, type 2 diabetes, high blood pressure, for example, heart disease, at lower levels of body fat. And it's probably genetic predisposition for that. For example, South Asians develop type 2 diabetes 5 to 10 years earlier than Caucasians. So this is something that's been missed from the discussion. In fact, in this paper, this almost entirely explains why people from BAME backgrounds have been adversely affected from COVID, or disproportionately affected from COVID. And this has not been rebutted or refuted. Once you correct for risk factors, there's no increased risk of death. But those risk factors are much more prevalent. And then you look at triglycerides and HDL as well, from markers of blood cholesterol. Now, this is a really big major problem, which is not part of the mainstream discussion. It's not part of a discussion in primary or secondary care. These are very relatively cheap, simple markers to measure. But if you have 3 of those abnormal, then you've got metabolic syndrome. Now, if you just forget about COVID for a second, we've already highlighted that it's the biggest risk factor for death once you account for age. Then if you have metabolic syndrome, then your risk of death, of stroke, of heart attack, all-cause mortality over a 10-year period is actually the highest than anything else. So even if you take COVID aside, it is the big issue when we look at chronic disease and the major killers in the Western world. Furthermore, and this is again really important to acknowledge, is that metabolic syndrome or poor metabolic health basically affects around 43% of South Asians of normal BMI. Let me repeat that, normal BMI. So obesity itself is missing a huge cohort of people, not just overweight, but people with normal BMI who have excess body fat, who are at risk. And the reason for that is that obesity itself is really very crude and outdated measurement, because what you're looking at with obesity with a BMI is a very crude measurement, which just looks at your weight in kilograms and divides your weight in kilograms by your height in meters squared, and that gives you a figure. And if it's over 30, then you're obese. If it's 25 to 30, you're overweight. And if it's 18 to 25, you're so-called normal BMI. And now the reason that's a problem is there are many people who are vulnerable, who may be given the illusion of protection by their doctor that they have a so-called healthy weight, right? Doesn't exist. There's no such thing as a healthy weight. It's complete and total unscientific nonsense. No one should be talking about healthy weight. It's rubbish. It doesn't have any relevance. I find it very frustrating actually whenever I read things on websites and people talking about healthy weight. It just doesn't exist. If you look at different ethnic groups, even 20% of Caucasians with a normal BMI will have suboptimal metabolic health. And again, they're probably going to have the illusion of protection if they're being told they've got a so-called healthy weight when they may be at very significant risk. So when we look at optimal metabolic health, which is having all of those 5 factors in the normal range, only 1 in 8 adult Americans are now metabolically healthy, which is quite shocking. And that applies even to younger generation now as well. Only 1 in 4 of American adults aged between 20 and 40 are metabolically healthy. We don't have specific data in the UK, but given the fact that our obesity prevalence is probably is not far off America, I suspect our figures are very similar to the United States. So the different factors that play into this from an ethnic, from the perspective of ethnicity, are really all related to lifestyle. So it's the diet, it's physical activity levels. At the moment in the UK, if you're Caucasian, then about 60% of adult Caucasians in the UK are getting their so-called recommended levels of physical activity, which is 150 minutes a week of moderate activity. This drops down for both Blacks and South Asians to around 50%. So that's one other factor that plays in. Vitamin D status, which I will talk about as well, is another big problem, certainly disproportionately affecting people from ethnic minority backgrounds. So cross-sectional data, before we talk about vitamin D and COVID, cross-sectional data reveals that the overwhelming majority of South Asians in this country are either deficient or severely deficient in vitamin D. Deficient or severely deficient. I mean, that has not been addressed, and this goes back many years. So we look at data with COVID and vitamin D, huge association here. One study showed there was a 10-fold increased risk of death in people who had severe vitamin D deficiency versus ones that had adequate levels of vitamin D. There's been one randomized study in Spain that shows that vitamin D, giving patients vitamin D on admission to hospital with COVID, certainly has a massive improvement in outcomes. It was a small study, but did have a big improvement in outcomes and reduction in death. So I think it's quite clear that that link is there. If we take COVID aside, if you look at respiratory infections and pneumonia, vitamin D deficiency, randomized controlled trial data shows giving supplements does significantly reduce death rates. So there's no excuse to not give vitamin D. The risk of harm is very low. Toxicity is not a major issue. And we talked about this earlier, measuring vitamin D status is expensive. You don't really need to do it. I think most people should just be taking supplements, certainly through the winter months. And if you're South Asian or if you're darker skin, then I think everybody should be taking all year round, because we need, people from South Asian or people with darker skin need more sunlight to generate the same levels of vitamin D in the blood. So vitamin D is certainly another factor, certainly that plays into the reason why we have higher death rates in the UK amongst South Asians and Blacks as well. So when we talk about excess body fat, we're talking about really visceral fat or fat that develops around the abdominal cavity and the abdominal organs. And it's all linked to excess insulin, chronically raised insulin over a period of time, and chronic inflammation are probably the two pathophysiological measurements, or this is the etiology behind these conditions, which include heart disease. 2/3 of heart attacks now are patients who have metabolic syndrome, and probably more have some degree of dysfunction when it comes to glucose metabolism, either being pre-diabetic or having high insulin levels. And it's not just heart disease, it's stroke, it's cancer, it's probably Alzheimer's as well. So chronic hyperinsulinemia is really what we should be discussing moving forward. And you can actually have chronically raised high insulin for about 2 decades before you develop frank type 2 diabetes. One very simple, crude way of looking at metabolic health is actually just looking at your waist to height ratio. And you want your waist circumference, the belly button, to be less than half of your height, ideally. And if it isn't, then there's a very good chance that you've got some degree of metabolic dysfunction. And certainly that, for a lot of people, should be a reason to, at the very least, do something about it, but also get your blood glucose checked, get your blood pressure checked, get your triglycerides and HDL checked as well. So I'd been picking up on reading about all this research and data and related to my own work over a number of years around metabolic health and its impact on infection of COVID-19. And I did manage to, through my advocacy and activism, I did, push very hard and eventually managed to, get an interview on Sky News. This is when we first went into lockdown. I wrote articles in several newspapers. And then I decided to write a piece for European Scientists, which was press release, but, got a lot of interest. And this was just after Boris Johnson had got sick and had actually come out of hospital. And one of the things I mentioned is that for me, observing Boris and him becoming unwell, whereas his slimmer colleagues didn't. And having known Boris, or I've certainly had interaction with people very close to him over a number of years, I know that his weight was a big issue then and had been, despite the fact that he would, as a London mayor, would be cycling everywhere, going for jogs. He's clearly an epitome or an example of the fact you can't outrun a bad diet, because he was obese and still cycling everywhere, and it's all about what he was putting in terms of his diet. So I'd written this piece in European Scientist, and one of the things I mentioned is at the beginning of this pandemic, knowing that metabolic health and these underlying conditions were related to lifestyle, why did we not have public health messaging reinforcing what was a message which was already very powerful and effective about stay at home, protect the NHS and save lives? It should have been eating real food, protect the NHS and save lives as well. And the reason for that is that metabolic syndrome can be reversed within a few weeks of just changing diet alone. Doing nothing else, not doing one iota of activity. I'm not saying you shouldn't do that, it's good for you, but you could just sit on the couch, do absolutely nothing other than change your diet, and you can reverse metabolic syndrome. And that's been proven from clinical trials. So then I later on, again, wrote another article for the Telegraph, which was featured on the front page that time. And I was then invited on Good Morning Britain and speak to Piers Morgan, Susanna Reid, and then BBC News the same day. And this has, reiterated this fact that we should be talking about lifestyle, that these conditions are related to poor diet. And Boris likely got sick because of his weight. Now, interestingly, there'd been no mention of Boris's weight and his illness up to this point. The Times then made it a big news story the next day, my comments, what I'd said in Good Morning Britain. And Matt Hancock then contacted me and asked me to actually provide him with evidence linking obesity and COVID, but I told Matt that it was well beyond obesity, as I've told you in this talk. It's about metabolic syndrome and the role government had to play in really sorting out the food environment, as well as giving him the information on the science. And I was pleasantly surprised, that later on Boris obviously came out after I'd had an interaction with Matt Hancock. And acknowledged himself. Now, what was quite scary is you've got all of these people around him in Public Health England and everybody else. None of them had come out and mentioned it. It took this trouble-causing disruptor cardiologist to kind of try and make some noise for them to actually listen. And luckily, the media picked it up, and Boris probably read that and thought about it. And then he came out and said, "Yeah, okay, I acknowledge it." And that was a good thing. It was a good move that he's now talking about making efforts to tackle obesity on a population level with government interventions. The only downside was there was a big emphasis on cycling and all that kind of stuff, which has absolutely no impact on weight at all. I mean, it's complete nonsense. It's great for health, it's great for optimizing immune system, and certainly for mental health as well. But when it comes to weight, almost all of it is to do with what people are eating, and that needs to be the focus, because it's been playing into the food industry's hands for a long time, who are marketing and selling a lot of ultra-processed junk food with impunity, because they put a message to people that it's about how much exercise you do. And it really doesn't matter what you eat as long as you burn the calories from exercising, which is just complete unscientific nonsense and has been fully debunked. So my publisher, I was in the middle of writing another book, which will come out next year. And she said, "Stop what you're doing, Aseem. Can you write a book on the immunity and metabolic health? Because you've been talking about this." And I managed to write this book in a very short space of time to get it out quickly. I'm glad it's done very well. It's a Sunday Times bestseller and all that kind of stuff. But for me, the primary purpose was to change policy, as with my first book, and to get it out to policymakers and to really to doctors as well, to try and understand very simply about how metabolic health can be measured and what we can do through lifestyle to change it. So where does poor diet fit in the grand scheme of things? In general? Well, it's responsible for more disease and death than physical inactivity, smoking, and alcohol combined now. So when you look at deaths alone, 11 million deaths a year out of 60 million deaths globally are attributed purely to poor diet. But probably worse than that is the chronic disease that goes along with poor diet as well. Conditions like type 2 diabetes, hypertension, heart disease, for example. They are equally, if not more important than people dying prematurely because of poor diet. And what is poor diet? How do we define it? Well, there's been some confusion regarding that, but I think there's a growing consensus of opinion that ultra-processed food is probably what's driving more than anything else. So these are basically foods that are, that are industrially produced, are packaged foods that have usually 5 or more ingredients from an international classification called the NOVA classification, and usually have additives and preservatives. And the reasons that they are probably driving all of these chronic diseases, or certainly the biggest risk factors, is that these foods are designed in a way to be hyperpalatable. In the way the ingredients they put in are usually unhealthy oils, very high starch and sugar. They're not very nutritious, and the science is emerging that tells us they probably interfere with appetite control mechanisms, so they encourage overconsumption. And this isn't just your simple fast food that you get from McDonald's or Burger King or whatever. It's packaged bread. If you go into the supermarket and pick up a loaf of brown bread, it is toxic junk. It's a chemical concoction of toxic junk. Now, people are buying this stuff thinking it's good for you. Next time you go to the supermarket, pick up a packet, a loaf of brown bread, and see how many ingredients are on there, and you'll find that there's well over a dozen full of additives and preservatives, and this is being sold to people as being healthy. Absolute nonsense. So this is part of the problem as well. So you can't, people can't exercise personal responsibility when they're effectively being lied to by the food industry. Now, the other problem with ultra-processed food is that data reveals that it increases markers of chronic inflammation. And one of the mechanisms why excess body fat is harmful to the immune system is it increases chronic inflammation within the body, which in itself then causes disruption of the immune system. But the chronic inflammation over a long period of time is also what drives heart disease, type 2 diabetes, and probably cancer and dementia as well. So what can we do about it? So, pioneering GP, David Unwin in Southport has been, following up many patients over a number of years and sending almost 50% of his 150 or 160 patients with type 2 diabetes into remission. But it isn't just about type 2 diabetes, and this is purely from cutting out, refined carbohydrates and ultra-processed food. All the markers of metabolic syndrome improve. And I see this with my patients as well on a regular basis. Many people that manage to reverse the metabolic syndrome send their type 2 diabetes into remission within a few weeks of just changing diet. It can start that quickly. Probably the peak time for most people to have benefits from the dietary changes are about 70 days, but that's still pretty impressive. But some people can actually send their type 2 diabetes into remission within a few weeks of just changing diet. And on top of all of this, and this is something that caused me a little bit of disappointment, I think is the word to describe it, is we know that poor blood glucose control contributes to poor COVID outcomes. We know that we have this big problem with ultra-processed food. And in the middle of the pandemic, when NHS staff were extremely stressed, Krispy Kreme decided they wanted to use the NHS as a branding opportunity by donating 1,500 free donuts to NHS staff. Very cynical marketing ploy by a company that doesn't care at all about your health, doesn't care at all about your health. They have no legal requirement to look after your health. They are there to make money and make a profit. And this is what they did. And what was disappointing is the Royal Free NHS Trust decided that, they thought they would promote and endorse this, which I thought was quite extraordinary. I mean, this is a hospital I worked in for a couple of years and finished my training in interventional cardiology at. And the reason I found this very frustrating is that the BMA, the Academy of Medical Royal Colleges, and NHS England have now really put out policy statements saying that we should ban the sale of junk food in hospitals, and we certainly shouldn't be endorsing it. So this was, and this is, I've had conversations. I know Simon Stevens very well, and I wrote something with his clinical fellow a few years ago about improving healthy eating amongst NHS staff, which I'll show you shortly. And I know that he was appalled by this. I mean, we didn't have direct correspondence on this, but on other things related to something similar, he was pretty appalled with what was going on in hospitals. The BMJ reported on this because my tweet actually became a news story. And it caused a bit of polarization on Twitter amongst doctors, quite shockingly. But again, I just put this down to pure ignorance and lack of knowledge. Some senior diabetes specialists decided they were going to post pictures of themselves scoffing donuts on Twitter. I think, I don't think there was anything malicious in this. I think it's just pure ignorance. I think they don't. And by the way, these are diabetes specialists. So, you've got to ask yourself the question here, we're not sending type 2 diabetes into remission in the population. And maybe that's partly because even the people that we think are experts in type 2 diabetes don't know you can send it into remission from lifestyle or dietary changes. Now, let's learn from history. Big tobacco played dirty and millions died. How similar are big food? So when the first links between smoking and lung cancer were being published in the 1950s, what did big tobacco do? They launched a PR campaign to try and stifle that evidence and try and plant doubt in people's mind and confuse the public. But what else did they do as part of their PR campaign? they use doctors to promote cigarettes. They use doctors to promote and endorse cigarettes. So if you go on YouTube and you stick in more doctors smoke Camels than any other cigarette, you'll find an advert that was put out where it shows doctors sitting in their consultation rooms, smoking away cigarettes and talking about, certain brands of cigarettes being better than others. And this is, when you see Krispy Kreme doing that with the NHS, it was exactly the same thing all over again. But it's just very disturbing and shocking that that certain sections of the medical profession just fell for it and didn't realize what was really going on. And I must mention one other thing. Now, it's theoretical, of course, but it's possible that, say you're a pre-diabetic or a type 2, say you're an NHS worker and you're exposed to COVID and you have one Krispy Kreme donut that will send your blood glucose above 10. This has been experimented in some people I know with type 2 diabetes who've sent that into remission, and you get COVID at the same time. That could be the difference between life and death. No joke here. It's unlikely, but it's possible. So what is out there in the literature? Well, myself, Simon Stevens' fellow, and Terence Stevenson, who was then the chair of the medical Royal Colleges and then the chair of the GMC, as you probably know, in the Postgraduate Medical Journal, we put out an editorial actually just talking in a bit more detail about how do we improve the outcomes for NHS staff and the public. And we've got to acknowledge that more than 50% of NHS employees are now overweight or obese themselves. I suspect more of them will have poor metabolic health. Is that, one of the reasons for that is, of course, the food environment. Everywhere you go, we're subject to these ultra-processed junk foods, but the hospitals themselves have also become a branding opportunity for the junk food industry, because 75% of food purchased in hospitals is now ultra-processed and unhealthy. So one of the points we make about how do we change this is that we need to inform patients and the public that diet can improve health, and that's the responsibility of all healthcare workers, who should lead by example. But to do this, health workers need to have education, training, and access to information. That, unfortunately, is lacking at the moment. We've got some, beacons of hope coming from a couple of medical schools, a bit of postgraduate training, but most doctors know nothing about nutrition. And, a recent publication, BMJ Nutrition, revealed that medical students and junior doctors, from a positive side, actually felt that, 90% of them felt that that diet was extremely important to health, and that they would expect patients to know something about it, but they lacked the knowledge, confidence, and training to be able to do anything about it. So that needs to change. I think the other thing we mentioned is that we had to put the evidence base that dietary changes can rapidly and substantially improve health outcomes into the heart of the NHS. A publication I did a few years ago was one of the reasons that I became an advocate for this movement, was that the data when it comes to heart disease reveals that even within a few weeks to a few months of changing diet, you not only improve risk factors for heart disease very rapidly, but heart outcomes as well. Now, there is only a few trials, but the trials are still pretty impressive to show that, for example, a modified Mediterranean diet combined with other lifestyle factors can certainly have a very big impact in a short space of time. This isn't something that will take years and years and years. It's not just about weight loss. A lot of these benefits happen independent of weight loss as well. So, as soon as people start changing their diet, as soon as they start reducing this chronic inflammation that they've probably been suffering for years, those changes in biomarkers happen quite quickly. So another publication that I was co-author on not so long ago really explains the issue, the evolving science about chronic hyperinsulinemia. There's quite a busy slide here. I won't spend a long time on it. We've already talked about high insulin levels and excess body fat. But the other thing about high insulin is it's not just pro-inflammatory, but it's pro-thrombotic. So there is good data showing that when you actually, even if with people with normal blood glucose, if you raise insulin levels, it actually increases markers of clotting in the blood. So it's pro-thrombotic. And it's something that we need to really be thinking about. So the drivers really of high insulin are poor diet, they are being sedentary, they are poor sleep, and chronic stress. So those are the major lifestyle factors. And if we tackle all of those, then we probably, most of this burden of chronic disease would reverse within a few years. Just to finish up, for me personally, I think, the NHS has been under a lot of stress for a long time. And myself and my father sadly had to witness my mum, who died prematurely, a GP. Both my parents are GPs, actually, retired GPs. And she died prematurely at the age of 68 about a couple of years ago. And I wrote this article for the newspaper that they put on their front page because it was before the last general election. I think they wanted to influence the general election to some degree, but they felt that it was an important story to put out. And my mum, just a bit of background about my mum, she was overweight for most of her life. She then suffered a small subarachnoid hemorrhage because of high blood pressure in her 50s, carried on working in general practice and got better, made a great recovery. But her weight was still, she was still overweight, was still eating a lot of ultra processed foods. She was vegetarian, despite, starting swimming and being active. And she then developed quite severe osteoarthritis and rheumatoid. Her health gradually deteriorated over a number of years. My dad was her main carer. And it was really heartbreaking to see her become less and less mobile, walking around at the age of 65 with a walking frame. I mean, she looked, 20 years older. And then she developed discitis. She got an infection in her spine. In the same year, earlier that year, she'd had 2 spontaneous osteoporotic fractures of her pubic rami. So third hospital admission was infection in her spine, discitis, very, very severe pain, needing very high doses of morphine. But this was unfortunately a result of lifestyle habits over a number of years. But what was really, really quite sad was that the system was under so much pressure in our local hospital that she suffered a heart attack when she was in because of the stress on her system. And it took 9 days before it was picked up. And it was actually picked up by myself because an echocardiogram that was carried out to rule out endocarditis had failed to be looked at by either the cardiologist team or the medical team, both teams thinking the other one was looking at the results and acting upon it. And the physician who was looking after my mum sent the report to me. I was in London at the time. I looked at the report. I was shocked. I said, my mum's had an MI. Within a few hours, because they were giving a fluid for infection, she suddenly went to crashing pulmonary edema, which I diagnosed down in London because my dad and his friend who was sitting by her bedside while she was gasping for breath were unable to help her because the medical registrar was too busy and this was on a weekday, was too busy to see her for 2 hours. So she didn't get, treatment for 2 hours. And it's just shocking when you think that a medical family can still be a victim of our failed system. And this is a system now where we've got a shortage of 100,000 NHS nurses and doctors. But actually what's at the root of this problem, the fact we've failed to tackle prevention over a number of years. And because of our failure to tackle it, we've got a system that's under so much stress and pressure that we can't even provide basic quality care to every patient. And I'm sure there are many other patients whose families don't even know that their relatives are getting suboptimal care because they're not medically trained. They don't understand what's going on. And it's really, really quite sad. And it was very difficult for me. It was a very difficult article for me to write, but I felt I had a duty to put it out there so people can try and understand what's actually going on, because this is also now about self-preservation. People know in general practice and secondary care that we are seeing more and more patients with chronic disease. We have less time to see them, less time for, more, conversations that might also help them from terms of their mental health. And basically it's a mess. We've got a complete system failure here. And we need to really do something about it very quickly because it's only going to get worse. COVID-19 has probably highlighted this more than ever. So to conclude, I think we need to understand poor metabolic health basically means poor immune health. So if we improve metabolic health moving forward, even beyond COVID-19, we're probably also going to reduce the severity and the morbidity associated with many infections, especially chest infections and pneumonia, influenza, for example. Obesity is just a tip of a diet-related disease iceberg. Remember, many people with normal BMI will have diet-related disease. COVID-19 should be called a diet-related disease. The biggest driver of these risk factors is ultra-processed food. The good news is we can improve metabolic health within a few weeks of just changing diet. And that specifically means cutting out ultra-processed food and low-quality carbs. So these are carbohydrates that lack fiber. These are your breads, pastas, potatoes, starchy foods, for example. It doesn't mean that forever you have to completely eliminate them, but certainly many people with type 2 diabetes may need to. And people with metabolic syndrome may certainly need to curb them down to, a very small amount of the calories they're consuming. And ultimately, in order to fix healthcare, we really need to fix our food system. Thank you.
Thank you very, very much indeed, Aseem. That was a very clear and well put case for the food industry to be at the heart of what doctors should be looking at, and prevention being extremely important. And certainly much of what you've discussed rings bells with myself. I recognize in the description you gave some years ago that I was suffering the metabolic syndrome, and I was lucky enough to find a route out of it. So I'm very grateful to hear you speak, and I followed you for some time. So thank you. I'm just looking at the question box, and the first question, if it's okay, if I could just bring that up and just mention early on. Let's get there. Barbara Barton was just mentioned she's starting to do pulse oximetry for higher risk patients, and is asking if they're also diabetic, should we be intensifying their blood sugar monitoring and checking as part of the virtual ward? I wonder if you might comment.
Yeah, Patrick, thank you for that question. Very good question. Absolutely, yes. So even with people with MIs, heart attacks, who have diabetes, whose glucose control is off, if people go to ITU or are sick, we know that if their glucose control is intensified, they tend to have better outcomes. So certainly there is no downside for this, and absolutely probably going to be some benefit. So, and that can be, if they're able to eat, then certainly then it's making sure that they go on a low carbohydrate diet. And many of the types of diabetics actually will then need less insulin as well. So yeah, absolutely, really important.
Thank you. And from Kay O'Hanlon, looking back at the part where you're talking about the body mass index and the weight to height ratio, does your advice also hold with children? Do they fall in? Can you measure height to weight and act on that in children? Because I know in Hull we have one of the highest child obesity issues in the United Kingdom. So I'm sure.
Yeah, that's a very good question. I think the height to weight, the height to waist ratio, waist circumference ratio, this particular one is only applicable to adults. So I think we probably have to go with a more traditional BMI with kids. But I think as a parent, if your child, you'll know if your child is overweight, and you'll know what kind of foods that your child is eating. So I think that I think that a little bit of common sense, I think when it comes to kids, that's what I would say. I think the other thing I didn't mention about the problem with BMI specifically is that it doesn't take into consideration your muscle mass, your ethnicity, and your body fat percentage. So that's why BMI really is outdated, and we shouldn't be using it at all. Actually, I'll just throw it out, just forget about it completely. There's a small number of people who are obese by BMI who are metabolically healthy, but it's only about 1 in 200 who have optimal metabolic health or obese. So it is a marker, and of course, as weight increases, it does tend to increase the risk of these things. But the problem with the BMI, as I've said earlier, is that you're going to miss a huge number of people who are being told they've got a normal BMI, and in fact they're metabolically unhealthy. So we'll do a lot better for our patients if we look at the metabolic health, not BMI.
There's almost a case for arguing that doctors should have a tape measure around the neck and not a stethoscope to measure waist circumference and height, rather than concentrating on the cardiac, the heart side. I think maybe if we'd done a bit more of the measuring, then we might have done a bit better. So Alexander Abel is saying, thank you very much for speaking to us. I'd like to ask about your book, The 21-Day Immunity Plan. You said that there is research that shows that metabolic syndrome may be reversed in just a few weeks, which is very interesting. However, is there any published evidence that immunity can really be improved in 21 days?
That's a really good question. So, within actually even a few days, you can affect markers of the immune system, certainly from, there's published data on exercise. So if somebody is sedentary and they start doing moderate activity, then your natural, your T cells, all the immune function definitely improves. So that's there. So we've got that very basic stuff. Is there published evidence specifically showing that within 21 days that your immune system can be optimized or improved massively? There isn't specifically, no. But because we know poor metabolic health is a risk factor, it'd be very difficult to argue against doing that as a good thing. So if we know metabolic syndrome is going to worsen your outcomes from COVID-19, and you can reverse metabolic syndrome within a few weeks, it's very difficult to argue that that wouldn't have some impact on the immune system. But actually a trial where people have looked at markers of the immune system and then done it in people with metabolic syndrome, no, that doesn't exist. And she's right about that. So I think that, this is about optimizing the immune system with all the different things, with nutrition, with food, with vitamins, all that sort of stuff, which is there. And that's very clear cut and that you can do. And then it's combining it with improving metabolic health.
Thank you, Aseem. And we've got another question for Barbara. Should we give all our patients on the COVID virtual ward vitamin D? Just
Absolutely. Yeah. Absolutely. We said, I think there's no harm. I mean, I'm not aware, of course, if you look it up, you'll find something about vitamin D toxicity, but it's unusual and rare unless you're taking very, very, very high doses. So there's no harm from it. And I think absolutely. In fact, the one study from Spain that came out, they gave them vitamin D when they randomized people to vitamin D or not vitamin D when they got admitted. And certainly with the ones with deficiency, and they found improved outcomes. So absolutely, everybody should be on vitamin D who gets admitted to hospital. They should be giving them, in A&E, they should be starting vitamin D on these patients.
David Horton just wants to check a waist of less than 102 for a man or less than half my height. So he's just checking which, because he's not 204 centimeters tall. So I guess the 102 is just like a red flag. You should be less than that, but
yes,
half your height, isn't it?
Yeah, that's very specific definitions for metabolic syndrome. But yeah, he's right. I think a more for an individual, what would be better if you just look at the waist circumference would be there for it to be less than half of their height.
Thank you. I'm conscious of time, so I'm going to keep pressing. Thank you, Aseem. From Rani Bora, how do you motivate people who are living on food stamps, benefits, and long history of poor eating habits to switch to real food?
Yeah, so this is something I get asked a lot, and we all, especially as physicians, as primary and secondary care, certainly in the NHS, we deal with all demographics of people. And I certainly have had patients that have managed to improve their metabolic health significantly, even send their type 2 into remission, who come from the poorer background. So it's definitely doable, but of course it is harder because healthy food is more expensive than the ultra processed stuff. And people who are on, low wages and come from, more challenging backgrounds are going to find it more difficult. And that's why, for me, this is about government policy always that's going to have the bigger impact. I'm there to advance the science and to tell individuals and help them because I think that's part of what we do as doctors. But if we're really going to impact on this problem of obesity and chronic disease and diet-related disease, it's only going to happen with policy change. It's not going to happen through individual education because the biggest determinant of our behavior is the food environment. And if you look at history with tobacco control, it wasn't education. Education was important. It was actually about addressing the availability and affordability and acceptability of tobacco that managed to get the consumption of cigarettes, which was in the 1970s, was about half of the adult population was smokers, and now it's about 17%. And that only happened because of things like banning tobacco advertising, taxing cigarettes, and a very strong repetitive public health education campaign that smoking kills. If we did the same thing with ultra-processed food, which isn't going on at the moment, unfortunately, then I have no doubt within a few years, we'd reverse these pandemics. We'd reverse a lot of these type 2 diabetes, heart disease. We would see reversal in those trends. I have no doubt about it because we know in individual that happens within weeks. So, or it can start to happen within weeks. So this is what needs to be done. But yes, motivating those people, I think, is going to be a bit more challenging. Certainly the sustainability is going to be more challenging for them.
Thank you very much. Will Bates, I think this is a very interesting question. He's thanking you for the talk, but he's worried that legitimate criticism of the government and their response to this crisis will create widespread belief in the population that the government response is primarily responsible for the high UK death toll, as opposed to poor metabolic health in the population. I don't know if you want to comment on that. He's got a worry that the government response may be the focus of blame.
Yeah, so I think the question probably is I think what he's trying to say is that have we got this wrong by blaming the government for this high death toll? It's debatable. I think certainly, if we'd locked down sooner, we may certainly have saved more lives. But a modeling study actually looked at what would have happened if we had healthier lifestyles in this country. And it estimated, and it's a modeling study, but it gives you some indication, that probably half of the deaths that we've suffered in the UK would have been avoided if we had healthier lifestyles. Dame Sally Davis, it's something I've said before, Dame Sally Davis a couple of days ago, better late than never, eh? She came out and is basically, almost repeating what I've been saying for months. And she said that, this is the biggest probably cause of death. If you look at Daily Mail reported on it, but she specifically talked about obesity. So she still needs to catch up on the science about metabolic syndrome. But she said obesity was responsible for the high death toll in this country. And if you look at other countries with high death tolls, the USA, Brazil, India, these are all countries that have very significant problems with poor metabolic health. So I think that it's probably a combination of factors. But yeah, I think the way it was managed at the beginning certainly has not helped at all. But if we had healthier lifestyles, I think that would have been a much bigger impact on the death toll than the way the government managed it.
Thank you very much, Aseem. I've got not too many questions now left, but I'm just going to go through them in order, because I think we've got enough time to cover them. Is Dr. Joshi is wondering if there's any, can you link testosterone deficiency with metabolic syndrome? And are there advantages with testosterone replacement therapy in this situation?
Very quickly, there is a link, absolutely. Interestingly, people with metabolic syndrome can drop their testosterone. Excess body fat itself can have a big impact. Many of my patients, actually, one of the things they report when they reverse their metabolic syndrome is an increase in libido and an improvement in their sex life. And actually, when you measure testosterone in these patients, it does improve significantly. That's the first thing. But whether testosterone replacement itself, I don't think impacts on metabolic markers. It may have other impacts, but it doesn't impact on metabolic markers. But improving metabolic health can improve testosterone, absolutely.
Thank you, Aseem. Another question is whether, from Dr. May, from Esme, whether Dr. Malhotra has a view on the benefits or otherwise of reducing eating time and intermittent fasting, where eating is restricted to an 8-hour period in 24.
Yeah, so there's a lot of debate recently about intermittent fasting. When it comes to markers of metabolic health, there isn't really much difference. I think for some people it suits them. If you can do it, great. I think one thing we need to think about is, this obesity epidemic really only started to pick up in the 80s and 90s. If you go back, 50, 60 years, there was hardly any obesity and people weren't thinking about time to eat. And it was just a very natural thing that they didn't need to think about it. And it's basically because the ultra-processed foods is what's driving this problem. So as long as people eat real food, that in itself will help control appetite, and then your body will respond accordingly. But if people, I'm not against intermittent fasting. I think for a lot of people, they find it helps. There may be some data, mainly from animal studies, that there may be a benefit from intermittent fasting and longevity and all that kind of stuff. But when it comes to metabolic health, there isn't really any increased benefit once you cut out the ultra-processed food and low-quality carbohydrates.
Right, I'm gonna
so basically just eat when you're hungry. Once you've done that, and eat till you're full.
Thank you. See, absolutely. I have to say, I agree very much on that. And I found that I have to fast a little bit for it to work with me. Kay O'Hanlon has mentioned would good food in school. Sorry, she's commented good food in schools would help with metabolic health in children, but unfortunately, school meal services are using outdated, well-balanced meals and have seed oils, low-fat margarine, low-fat milk, cereals as healthy options. So I think that's a comment, and I'm sure
she's right.
Yeah. Would you be able to give a comment on your view of whole food, plant-based diet versus the Mediterranean diet in reversing coronary artery disease? That's
wow. I'm writing about that at the moment for my next book. But I'm very happy to mention. So there's one study, which is a very small study, which didn't prove that a plant-based diet reversed coronary artery disease, but a number of factors that included a plant-based diet may have some impact. But I think the thing to think about here is, and I'm speaking as someone who is the son of a mum that died prematurely, who was a very strict vegetarian, is that you can have a very unhealthy plant-based diet and you can have a very healthy plant-based diet. I think when we talk about plant-based diet, I suspect she's being more specific about being vegan. And the issue about veganism, I think the only real strong argument for veganism is really the ethical reasons that I understand that, the only animal products or animal flesh, but it is a nutritionally deficient diet. Almost all vegans have to take supplements and B12. So that's something you have to be careful about. It's certainly not a diet we evolved to eat. Human brain actually 3 million years ago expanded because of meat. So as long as people understand exactly why they're on this vegan diet, and are making sure that they are careful to avoid nutritional deficiencies, then of course it can be very healthy. In terms of heart disease reversal, there are some studies showing that even a very high fiber vegetarian diet, which is doesn't have any ultra processed food, probably has much stronger case actually for potential heart disease reversal than a plant-based diet. But I think what's crucial in these studies, and I'll talk about it, is it was multifactorial intervention. It was stress reduction with very strong meditation. It was not being sedentary. When you synergize these things together, that's probably what has the impact. And some of my patients are a few of them, I'll be writing up case studies on them, have shown some degree of heart disease reversal from the interventions I've been doing with them. And one of them is actually a meat-eating ketogenic guy. And he's managed to stabilize and probably reverse some heart disease within a few years by going on a ketogenic Mediterranean style diet. So I think there's probably different approaches here, but it's multifactorial. It's not just the food. It's probably stress has a big role to play as well.
Thank you, Aseem. You've done fantastic. I think just one more question, and then I'll pass over to Varun just to round up. Marakina Studentmeyer has asked, are there any tools, ways we can empower patients to assess, track their metabolic health from home, comparable, perhaps similar to assessing their weight regularly?
Very good question. I think you can probably only realistically do two things at home, but are still very helpful. One is your tape measure and your waist circumference. And if that's going down with your dietary intervention, it's likely that other things, your blood glucose is getting better, your trigs and HDL are also going to get better. So it's likely that's a very good surrogate. And also home blood pressure monitors. I mean, they're quite cheap these days. I think a home blood pressure is what, 20 or 30 quid. A lot of patients have them. And certainly, a friend of mine who, was a former MEP, and she wrote about this in the Telegraph. Her mum, who'd been hypertensive many years, during lockdown, again, she contacted me. I gave her some advice. And she managed to come off her antihypertensive pill that she'd been on for years, a Ramipril 10. And again, it happened, she was amazed within a few weeks of just changing the diet. So you can, yes, I think those are probably two things. Glucose monitors are very expensive, not probably viable for most patients. I think that, we know the science of what works. If people, implement it, it's probably going to have an impact. And then you can, maybe get all these markers rechecked with the GP after 3 months.
Thank you very much indeed. I'll now hand over to Varun Anand.
Thanks, Patrick. And just to say thanks very much, Aseem, again, for your talk. In terms of waist circumference and tape measures, if people are interested in getting one and measuring it just so you know how to do it, it's roughly the belly button, but it's technically halfway between the bottom of your ribs and the top of your hip bone, which is not always the belly button, so just be aware of that. But yeah, that's a great way to do it at home. Thanks.
And you should do it relaxed, Varun, as well, right? You should be like,
that's right. A natural breath out, don't suck it in. That's spot on. Unfortunately, a lot of people and patients do suck in when they measure it. So yeah, that's an important point as well. I forgot to mention that. So yeah, no, just to say thanks very much. Really thought-provoking talk. Hopefully, it's had a lot of impact on people in whole. And who knows, it might even prevent some people getting admitted in a few weeks' time as the pandemic is going over the next few months.
And Varun, I would say also people want a bit more. I mean, it's not a long book. It's probably a 2.5-hour read. And there's very specific recommendations and plan in there around the foods and the science, etc. If people want to read more detail, I think it's now $5.99 on Amazon or whatever. So I think that would probably be helpful as a resource as well.
I'm sure it will be. Thanks very much for that. And just to let the members know, we are hoping to have a next talk in December, not finalized yet, but hopefully on a lighter subject, perhaps something to do with happiness and positive psychology around Christmas time. But it's safe for the members.
Varun, one final thing I think for everybody, which is free and open access, I think will be very helpful to read, is if you Google The Physician, the journal The Physician, put my name in BAME and metabolic health, that editorial actually covers a lot of this stuff. It has all the markers, but it talks about all the different lifestyle stuff, and I think people will find that very interesting and helpful.
Yeah, you had a slide on that here, and I made note of that myself.
It's one of the slides. So I think, and the references are there also to the studies that show that the improvement in metabolic health or metabolic syndrome happened very quickly. So you can then look those up and read them if you need to.
Fantastic. Perhaps we can download that with Patrick and maybe share that with the members after this talk. That'd be great. So yes, thanks everybody, and thanks particularly to Aseem. Good evening, and hope to see you next month, everybody. Take care.
Thank you. Take care.
Thanks.
Bye.
Bye-bye.